If you have read the headlines lately, you have seen two completely different stories about the same drugs. One says GLP-1 medications like Ozempic, Wegovy, Mounjaro, and Zepbound slash your cancer risk. The other says they might raise it. Both stories are out there right now, sometimes on the same day, and I want to tell you something as a registered dietitian who works in oncology. The truth is calmer than both headlines, and there is a part of this story almost nobody is covering that matters far more to the patients I see every week. First, let me explain what these drugs actually are. They are incretin mimics. They copy hormones your gut naturally releases after you eat, hormones that tell your pancreas to release insulin, slow down your stomach emptying, and signal your brain that you are full. The result is better blood sugar control and a serious drop in appetite. For many people, that adds up to dramatic weight loss, often 15 to 20% of body weight. Now the good news headlines. Several large observational studies have followed people with type 2 diabetes or obesity who take these drugs and compared them to similar people who do not. Some of these studies suggest lower rates of certain cancers linked to excess body weight, including colorectal cancer, pancreatic cancer, and a handful of others. That is genuinely encouraging, and it is biologically plausible. We know obesity is connected to at least 13 cancer types, likely through chronic inflammation, insulin resistance, and hormone changes. So, if a drug produces major weight loss, we would expect some cancer risk to come down with it. The honest read is that the benefit is probably mediated by the weight loss itself and the metabolic improvements, not some magic anti-cancer property of the molecule. Now, the scary headlines. These drugs carry a boxed warning because in rodent studies, they caused thyroid, C-cell tumors. Rats and mice have far more of the receptors on those cells than humans do, so we do not know whether that risk translates to people. But out of caution, these medications are contraindicated for anyone with a personal or family history of medullary thyroid cancer or a genetic syndrome called MEN2. If that is you or your family, these drugs are simply not for you, full stop. Beyond that, some early analyses hinted at a possible thyroid cancer signal in humans, while other analyses found nothing, and there have been conflicting reports about the pancreas as well. The data are genuinely mixed, which is exactly why the headlines whiplash back and forth. Here is the key point about both streams of headlines. None of this comes from a randomized controlled trial designed to measure cancer outcomes. The encouraging studies and the worrying studies are almost all observational, meaning researchers watched what happened to people who chose or were prescribed these drugs. People who take them differ from people who do not, in ways no statistical adjustment can fully erase. They may see doctors more often, get screened more often, or have different baseline health entirely. Association is not causation in either direction. So when a headline says, "These drugs cause or prevent cancer," the accurate translation is that we see a pattern worth studying, nothing more yet. Now let me take you into my lane, the part of this conversation I almost never see covered. What happens when someone taking a GLP-1 gets a cancer diagnosis and starts treatment? This is where I actually worry, and it has nothing to do with tumors in rats. Cancer treatment itself suppresses appetite. Chemotherapy, radiation, immunotherapy, surgery recovery, all of them can make eating feel like a chore. Now stack a powerful appetite-suppressing medication on top of that. I have sat with patients who simply could not eat enough to get through treatment, and the drug that was helping them 6 months earlier was now working against them. Here's why that matters so much. When your intake drops that low, you do not just lose fat, you lose muscle. And muscle is not cosmetic in oncology. Patients with low muscle mass tolerate chemotherapy worse, have more dose reductions and delays, more complications after surgery, and in study after study, worse survival. Unintentional weight loss during cancer treatment is one of the most dangerous things I see, and it is the exact opposite of the intentional, supported weight loss these drugs were prescribed for. This is why an oncology team will often talk about pausing the GLP-1 during active treatment. Not always. Someone with well-controlled diabetes on the drug might stay on it with close monitoring. But if weight is falling fast, if nausea is stacking up, if protein intake has cratered, pressing pause is often the right call, and that decision belongs to your medical team, not to a video. And if you do stay on one, or you are on one now while healthy, the strategy is protein-first eating. Your appetite window is small, so spend it wisely. Protein at the start of every meal before anything else. Eggs, fish, chicken, Greek yogurt, tofu, beans, milk. Aim for a palm-sized portion of protein 3 times a day at minimum, and pair it with some kind of resistance work, even bodyweight exercises, because protein plus muscle use is what tells your body to keep the muscle and burn the fat. So here's my bottom line. If you are on a GLP-1 and you receive a cancer diagnosis, tell your oncology team about the medication on day 1, not week 6. Ask directly whether it should continue during treatment. And ask for a referral to an oncology dietitian early, because protecting your muscle from the very first cycle is far easier than rebuilding it later. As for the headlines, do not let either version scare you or sell you. These drugs are neither a cancer cure nor a cancer cause based on what we know today. They are powerful tools with real benefits, real unknowns, and a real need for supervision, especially when cancer enters the picture. That calm middle ground does not make a great headline, but it is the truth, and you deserve the truth.